Welcome to a three-part series, Immediate Full Arch Reconstruction with Guided Surgery and Prosthetics. It is being presented by Dr. Douglas Diddy, DMD, MD. Tonight is part 3, Complications, and we are going to begin the webinar shortly. And with that, it is my pleasure to recognize one of our panelists, Tremaine Watkins, CDT. He is our Clinical Director of Guided Surgery Implant Solutions, and he will be available to assist with any questions, comments, or concerns. And now it is my pleasure to turn over the reins to our very own Hallie Wyrick. She is the Director of Sales, Implant Solutions, and Guided Surgery. Take it away, Hallie.
Thank you. Good evening, everyone. I'm so happy that everybody's able to dial in tonight. This is a lecture I've really been looking forward to on complications. So I'd like to introduce Dr. Douglas Diddy to you all. He is an oral surgeon practicing in Delaware. He's been named a top doctor in Delaware today and each year since 2006. He focuses on TMJ, implants, hard and soft tissue, full mouth reconstruction. He's been utilizing the Unsequenced workflow for over 5 years and hundreds of cases. We were even discussing tonight. He's even had the pleasure as an oral surgeon restoring a few cases. So he's going to share some of his pearls and, like I said, the complications that we all get to see, or we don't get to see because we're always focused on these beautiful cases start to finish. But I think this will be a really captivating lecture this evening. So Dr. D, looking forward to it.
All right, thank you very much. That's a lot of pressure. So welcome back, everyone. I'm sure many of you have been here for some of the other parts 1 and part 2. This is part 3. Those of you that are have not been here for the other parts, we started off with part 1 talking about case selection. We started talking about case acceptance, when to do cases, when not to do cases. Part 2, we discussed, details of surgery and details of how to restore these cases. And this is part 3. We will discuss some of the potential pitfalls, some of the complications. We will discuss hygiene, and we'll talk about some of the things intra-op and that happen that in ways to work around some of these issues. So welcome. I just want to also say that it is an absolute honor to speak to all of you about this topic, because it is really a passion of mine. It's been a passion of mine since I graduated dental school, and in dental school I was able to restore 2 cases, and as a dental student, which is fairly unusual. And I won't even tell you how long ago that was, but it was a while ago. So since then I've done a lot of cases, and this is absolutely one of my passions. So hopefully you can get something out of this. A lot of the things I'm telling you tonight are also backed by research. And so first we want to talk about maintaining the long-term fixed devices that the patients get. And for patients, one of the primary tools that a patient will need is a water pick. At the end of every case, if they don't have a water pick, I typically give them one, because it's so important to their hygiene and taking care of these long-term provisionals, or these long-term final prosthetics. And they need to clean underneath with this water pick. These are sort of common sense. You all know these things, but super floss with floss threaders, especially if there's any space underneath that they can work these floss threaders through. Most patients should be able to work floss threaders through, be able to clean and floss these things. We do encourage night guards as well for anybody who has a heavy bite or bruxism. Now, for the clinician, for your offices, a very, very important thing for these patients is that they have regular hygiene visits. And I'll explain why that's so important. There's a lot of studies on patients that have regular hygiene with these devices and patients that do not show up. And there's a greater than 50% chance, there's a 50% greater rate of implant marginal bone loss and peri-implantitis for patients that don't do their regular hygiene visits. And then you as a clinician need to decide when to remove these devices. And this is a subject that is, there is no consensus. So I will tell you what I've learned just from talking to a lot of clinicians, as well as reading a lot of articles, and there's still no consensus about what you should do. A very common way to take care of these devices in your office is to remove them every 2 years and clean them and put them back on. Some doctors, you should replace the gold screws as well. Some doctors replace the screws every other time. Some doctors don't remove them, especially if there are no issues. Some remove them every year, but decisions about removal do need to be made on a case-by-case basis. So definitely regular hygiene maintenance decreases peri-implant disease. This is extremely, extremely important. So just because these patients have removed all of their teeth and placed these devices does not mean they're finished with their dentistry. When to remove a device? Well, whenever, part of it is prosthetic design. So if a patient has a flange or limited access to cleaning the implants, these devices should be removed more often and cleaned more frequently, maybe on a yearly basis. You want to have the undersurface. It's not really always possible to do, but an ideal undersurface of these devices would be a convex surface. So it would be a lot easier to clean and for a hygienist to access and for even the patient to clean. You definitely want to remove these devices if there are any signs of peri-implantitis, if there's any pain, if you're noticing excessive plaque and calculus, or sometimes patients just have difficulty with maintenance, sometimes due to prosthetic design, but other times, we're dealing often with the elderly population. It may be difficult for them to have the perfect hygiene. So you have to make your own protocol, but be able to alter it based off of your patient's needs. So there's no consensus, but a lot of doctors remove them every 2 years, if even if everything looks good. In the literature, problems are separated into two general categories, technical and biological. So technical is related to the teeth and the prosthetics. Biological is related to the implants and the peri-implant tissues. So long-term maintenance complications, this is related to the long-term prosthetics. So wear on the teeth is very common. Loosening of the prosthetics are very common. Wear on the adjacent teeth on the opposing arch, very common. Fractured teeth, not so common. And fortunately, fractured prosthetics are extremely rare. These photos on the right are actually photos of one of my patients, and this patient was a heavy bruxer. This was done years ago, about 8 years ago, and eventually this patient fractured a tooth and then actually fractured the metal. If you look closely at his lower arch, you can see there's his hygiene is not so good. Even his lower arch, he is not brushing very well. There's plaque and calculus everywhere. I'm going a little bit slow with these first couple slides. We'll speed up in a minute. But I do want to take a moment to discuss literature. One of the things that we did in the medical school I went to was every week we had a literature review class where we discussed articles, research papers, and then we discussed the quality of those papers. And I don't know about your dental schools, but I know that we did not do this very much in our dental school. So it really, really was eye-opening and helpful when it comes to reading articles. It's very important that we evaluate papers we read with a critical eye. So one of the papers that just came out, which summarized the complications with these long-term devices, was extremely negative. And the summary was they reported that 100% of these devices long-term had technical complications by 10 years. The problem with that is that just about all of these devices were acrylic fused to metal. The newer devices with the zirconium and the porcelains or nano ceramics, they just haven't, we don't have as much literature on the technical complications associated with those devices. And most of the complications were just wear on the teeth. So yeah, we do have a lot of small amounts of wear on the teeth, but this author also admitted that it was extremely rare that the prosthesis fractured, and also admitted that just about every complication was repairable. So this patient that I just showed you had the metal fused to acrylic prosthesis removed, and then had both upper and lower. Eventually, we did the lower as well. We made the final prosthetics in zirconia. And this is a much more hygienic prosthesis. This is a year after it was placed, and it does appear that he is maintaining everything better. And it does appear that there is access to the teeth, or to the good hygiene. So prosthesis loosening ranges from 2.9% in literature to 12.3%. And that's also one of the more common problems with long-term prosthetics. Sometimes you need to tighten them back up, and depending on what type of materials you're using, how heavy your patient's bruxism is. These are contributors to these technical complications. It's all common sense, but I also pulled this out of the literature, so I think you already know this. But patients that are heavy bruxers are more likely to fracture off teeth and have these technical complications. The materials you use are more prone to technical complications, such as acrylics break easier, especially in somebody who has bruxism. This is an actual case on the right side. This is a final prosthesis that was made, and of a case. This is a long time ago, and the restorative doctor I was working with, in my opinion, this has way too big of a cantilever. So I've absolutely lost touch with this patient, but I can imagine that at some point a fracture was likely to occur on this prosthesis. Make sure that your prosthetic has the proper height. That's one thing I really like about using a digital flow. Again, in Sequence is my preferred digital lab, where the height of the prosthetic is never an issue when working with them, because we always have that calculated in our digital plan. like I said, the implant and prosthesis survival after 10 years, according to one large study, was over 90%, and most of the problems were repairable. Biological complications are problems around the implants, and these are much more concerning because if the implants fail, the prosthesis essentially fails and has to be redone. If we need to redo implants, the whole thing has to be redone. Peri-implant mucositis, peri-implantitis, marginal bone loss, infections, and pain are the big complications we want to look for. The patient on the right was having pain and was sent back to me from the restorative doctor. And I don't have the x-ray here, but the patient did not have bone loss, but had primarily peri-implant mucositis. So we cleaned the prosthesis and sent them back for a good hygiene visit. But really, really important in the literature, very important concept that we all need to hear. The biological complications were over 90% after 10 years or by 10 years when there is a flange on the prosthesis. So in other words, when the patient does not have access to their own hygiene, there's a lot more chances of the mucositis and the peri-implantitis, the marginal bone loss, and everything else. This is the most boring slide I have, so I'm apologizing to you now. And I'm actually, the only time today, I'm just going to read you a lot of these statistics. 64% of the patients reported difficulty with hygiene when they had a flange. 11 to 50, 12 to 57% of patients ended up with peri-implant mucositis. 10% of patients had peri-implantitis when there was a flange and essentially difficulty gaining access to the implants. So your final prosthesis design is very, very important. 4.7, almost 5% of implants with a flange had bone loss of greater than 2 millimeters. But with a nice hygienic prosthesis, there is some good news. The average bone loss after 6 years was only 1.4. So really pretty low amounts of bone loss if the prosthesis is made in a hygienic method. So with good hygiene and a good prosthetic design, only 1.3% of implants showed a greater than 3 millimeter bone loss after 15 years. This is, yes.
Can I just add something really quick?
Yes.
As a lab technician, I would say, there's a lot of things that are involved for us in making one of these prosthetics. And it's sometimes we look at it like a big tonic. And so we might design it like a modified ridge lap. And so as you guys can see, as Dr. Diddy's pointing out, having these hygienic on the intaglio surface is kind of a key. So I think this is an area where you can kind of help your laboratories and be a resource, because a lot of times the reason that it has a flange is because maybe the gingival contour is odd or the ridge is kind of peaky or whatever. And there's going to need to be some discussion and perhaps some guidance as to how to avoid that. So kind of if you guys are the intaglio police, you'll definitely be helping your laboratories, whether they appreciate it or not. And you'll definitely be helping your patients. As Dr. Diddy pointed out, that's probably the biggest thing you can do to position yourself and your patient for long-term success.
Yeah, so thanks for bringing that up. Certainly, sometimes it's unavoidable to have a prosthesis that's not designed in the ideal way. But going back to the first thing we discussed today, then your hygiene maintenance plan may be different. So you may tailor your maintenance plan in a different way to patients that have a less hygienic prosthesis. This is an extreme case I showed in the first lecture, but significant periodontitis has been shown in the literature to be associated with peri-implantitis after implants are placed. So I think we all know that, but it does show in the literature that for these tooth and a day cases, this is this is a legitimate case, but we cleaned up this first. We took out all the teeth first. You would never do a immediate load prosthesis in a situation like this. But eventually, it was a lot of lifestyle changes that she made, and we were able to proceed with one of these cases. These are the provisionals. Contributing factors to biological problems, I want to highlight the first two, which is age and smoking. Age and smoking have been the top two most highly contributing factors in the literature to development of biological complications. There were two studies that seemed pretty good that actually showed that smoking was not a contributor, but that goes back to my point of evaluating literature and reading everything and keeping an open mind, because the vast majority of studies showed that smoking is a contributor to marginal bone loss and periimplantitis. We talked about prosthetic design, we talked about hygiene access and hygiene visits already, and cleaning off the biofilm. Biofilm is, biofilm builds up. It is reported to, as you know, to lead to periimplantitis. I'm going to discuss number of implants in just a second, and implants, there seem to be more implant failures, more marginal bone loss, more biological complications in maxillary arch prosthetics than mandibular arch prosthetics. I'm going to show you a case now, just to illustrate a point, and it's not a tooth and a day case, but this patient had significant bone loss, and both in the horizontal and the vertical planes. And as you can see, that there's bone loss all the way up to the apex of the adjacent teeth. And I tackled this with some complex bone grafting. And I was eventually able to achieve about 6 millimeters of vertical height and more horizontal width. And this is the day that I took off my titanium cage. But the point that I'm making here, which is something brought up in the literature, is that implants placed in augmented bone have a higher rate of failure. And so these augmented bone cases will not be cases where you would do an immediate load prosthesis. Now, my opinion on this is that this is mostly for using allogeneic bone type things. So with augmented bone, 11% of implants had pocket depths of over 5 millimeters after 9 years. So I rarely, if I augment a lot of bone, I will rarely load the case. This is my implant. I was fairly happy with this case. You may not be real impressed with the final prosthesis, but I was extremely happy. I did a connective tissue graft, and I think the implant turned out beautifully. And this is the final case. And the disappointment here is this picture, this photograph was taken 5 years later, and she is not taking care of this situation. There's plaque and calculus everywhere. And I think the prosthetic design, it's not my place to say. It looks like it was made to try to allow for having a nice gingival fill between the teeth. But there's no studies on using autogenous bone. And I'm a huge fan of using autogenous bone. Here's a good example. I had a very narrow ridge in the posterior mandible. I used autogenous bone. And in general, I mean, I don't place less than a 5 millimeter implant in posterior mandible. So if I need to, I'm quick to graft those areas. And autogenous bone seems to develop amazingly dense, very good bone for me. So when I do autogenous bone, I may consider still loading a case. This person came to my office, and we'll illustrate a few points. She was unhappy with just about everything that was done. And this was a first prosthesis she had, but this was made as the final prosthetic. And I really don't have a big problem with this prosthesis. By the way, I will, reiterate something I said last time, and that we need to all support each other. When we see somebody coming in with problems, we're not, and we shouldn't throw our colleagues under the bus, because none of us have had a perfect career. And to be honest, I can't actually complain about anything done here. The one thing that I don't like in this situation, I suppose, is that there's not much access to cleaning these implants. There's a large flange, and she doesn't want the plastic anymore. She wants to transition into zirconia. And so I have an x-ray of her implants. The problem is there's a lot of bone loss around these implants, and this device was only placed 3 years ago. It was extremely well done. And when we do implants with prosthesis, immediate load prosthetics with 4 implants like this, we tilt to distal implants and we place longer implants. And unfortunately, there's still a lot of bone loss on this case. So very important contributing factor is implants less than 10 millimeters. So if we have implants longer than 10 millimeters, there is a lot of research showing that there is much less overall marginal bone loss. And then there are also some studies now justifying placing more than 4 implants. So the number of implants did correlate with marginal bone loss, but this case was done extremely well. Unfortunately, she has almost 50% of bone loss on these anterior implants. So this is a case that we're going to have to decide what to do and maybe replace some implants before we proceed with the final. Photos may not do justice to just how much lip support this patient needed. The photo on the right was without her denture, and the photo on the left was with her denture. And what I want to discuss here is that there needed to be a flange. And this is maybe a better case for a bar overdenture. You can still start off with immediate load prosthesis, but then the eventual plan may be better served as a bar overdenture. This is 7 years after these implants were placed, and I think that this bar allows for really good hygiene, and she's taking very good care of it. Another thing I want to say about her is that she is a smoker. She's over the age of 50, and she had augmented bone. Here's the prosthesis, and when she pushes these push pins, this locks onto her bar, and she actually feels that this is locked on and feels that these teeth are very sturdy. But she can take it out very easily and clean it at night. So again, the chance of implantitis, according to studies, is approximately 14% if this is fixed and never removed, and 57% mucositis. Now, because she had augmented bone, this is not an immediate load case. I started off with 7 implants, but I lost 1. But this x-ray, if you look closely at these implants, this is 7 years later. And remember, she's a smoker, it's augmented bone, and she has great access to hygiene. So the author that wrote the recent paper that was a little negative, one of the suggestions is that these bar overdentures should be used far more often when there's a need for a flange. The mean crestal bone loss of a bar overdenture over 5 years averages only 0.7 millimeters. So short-term technical complications, we're now moving into the long-term provisional. This is the item that you've given your patient if you do an immediate load case. And fractured teeth and fractured devices are far more frequent for these long-term provisionals. They are usually made of all acrylic, but they can have a metal reinforcement. There's been no major differences in the rates of complications with either one of those devices. The other possible complications are midlines may be off, malocclusion. You're going to often have some more malocclusion with these than you will with your final. They're bulkier. There will be more gaps under the devices, difficulty with speech, and often less teeth on this provisional. We take out a premolar. We don't want the cantilever back as far. And to me, this is a very important slide for you all to take a screenshot, take a photo, because these are realistic expectations I want to give my patient before we start. And when I started discussing these things with the patient before we do the surgery and let them know that all these things are normal, the patients seem far more satisfied with this, knowing that they're going to get a second device. And that's the time that all of these little problems will be fixed and the occlusion will be dialed in. Here's a case from years ago that I did with using conventional means. And I thought I had the proper bone reduction, but clearly we did not. So this device, when he smiles, you can see the edge of the device. And I hope you're not all judging me here, because I am tasked to show you the bad stuff today. I could show you hundreds of perfect cases, but today we are showing you the problems. And this device is more likely to fracture. Fortunately, it did not. But anybody is a bruxer, it's way more likely to fracture. And it's more fractures were associated with the male gender. This device was eventually removed and it was replaced with an all zirconia device with a small amount of pink porcelain due to his high smile line. And it actually turned out really nice, but he did move away. So I do not have a final copy or photograph. This is his device. So the fracture rate of the device is the most common complication, as I've already explained. Within 9 months, 7.4 to 17% is the approximate fracture rate. This is another patient. This is her long-term provisional. And I started getting texts about things like this. She didn't like the shape of the canine. And there were a lot of texts about things like this. And the point of this is that you should give your patients, good realistic expectations before you start, especially with the long-term provisional. They're not perfect. And we were able to reassure her that we can correct and fix these things for her final. And again, this is her long-term provisional with a over-exaggerated smile, and a few weeks later, teeth broke off. So this was a tough case, but it was eventually turned into zirconia. Again, I'm showing you things that aren't perfect. There is a cant to her device, but she does not have a lower device. And so the only way to fix this would be for you to build up the lower teeth, especially on the right side, and then you could fix the occlusal cant on the top. Implant failures are not as common as I thought, although it was very difficult to find a real accurate number in the literature. I'm not exactly sure why. One thing that is clear is that the most likely implant to fail is the most distal implant, probably because of the posterior biting forces and the cantilevers. Implants fail more often in wider ridges. And of course, when there's not enough primary stability, don't forget that in order to load a case, you need at least 30 Newton centimeters, but I don't like 30 Newton centimeters. I really want every implant to be above 35 Newton centimeters, especially a posterior tooth. You need to have enough implant support. This case of a failure on the right, I would say, is a case of not enough implant support. It's the basketball on a toothpick effect. Poor quality bone certainly leads to biological failures. We mentioned smokers, maxillary bone. We mentioned posterior implants, cantilevers, and non-compliance. The first lecture, I showed you a non-compliant patient of mine who was a IV drug user, and fortunately, the one and only absolute failure I had with the entire device. She did not come back for over a year until finally she came back. A quick word on failures. I have a policy in my office where I have a written policy where failures of implants receive a full refund. That's my policy. Not everybody agrees with that policy, and I urge you all to adopt your own policies on what to do. And I feel very strongly about that for my patients, and I know they're very appreciative, but it is impetus for me to try my best to not have failures. Here's a case where he had 6 implants and the most distal one failed. So he still has 5 implants. And if you look at the lower arch, he only has a second premolar occlusion. We got lucky this time because most cases with a distal implant failure, you need to replace and then wait longer. But as you can see, there's not a lot of cantilever. So we were able to proceed forward and finish this case with 5 implants and refund his implant. Here's a case where another doctor in my area was trying to place locators, and this time used implants that were too big, and they haven't even been restored yet, and the implants have significant amount of bone loss, and he tried to graft on the outside surface of these implants, and it really doesn't take very well if you're grafting directly onto large areas of implant surface like this. Again, I feel very strongly we can't throw our colleagues under the bus. We move on. We say this can happen to anybody, and we correct the situation, which involved removing them, bone grafting, and I ended up placing several smaller implants, and then we proceeded with a fixed prosthesis later. This is another case of an upper augmented bone. I did show you this last time. My opinion is this is a very important slide for all of you, and this is related to the transitioning phase of going from the long-term provisional to the final. When you're going from long-term provisional to the final, if again with digital labs, especially my experience with in sequence has been that, again, I'm showing you bad stuff today, but most of these cases just are spot on. The midlines, the occlusion, and everything just seems most of the time to just be right where we want it. If that's the case, as I showed you in the second lecture, proceeding forward with the final via digital means, we showed you how to place impression material underneath the device and on the occlusal surface and send it back and they will essentially send you back either a wax up or the final. I have, and this is my opinion, I've recommended to always get a wax up. And a little pro tip on wax ups, make sure your patient doesn't bite down very hard on them. A local doctor had somebody bite down very hard on it, and the whole wax up shattered, and then they had to start over. But if a lot of things are off, the cants, the midlines, the occlusion, smile edge, you need to make sure that you can get a nice prosthesis with the materials you want and hygienic access to implants. You need to think about all of these things when you're going to make your final. And this is, again, another picture I would take, another photo or a screenshot I would take, because these are the things that you should look at. You should look at all these things when you're going to make your final, prior to making your final. And if you need to make a lot of changes, you can either do it, it's going to take more steps for you. You can either do it using digital methods, and digital methods will involve taking a lot of photos and maybe putting scan bodies on and scanning everything. You have to have proper photos, of course, straight on. Or you can do it with analog means, and take, an articulator and mount these cases and take a lot of impressions. But either way, you can make changes. You just need to work with your lab to be able to, communicate, make sure your lab can help you make all of these changes. This is her final device. It was a nice hygienic device. It was convex underneath, and she got a beautiful result, both upper and lower zirconia. Intra-op complications now, I don't want to call it all complications. A lot of these things are just normal part of doing these procedures. There's often some little changes that need to be made. We need to think on our feet. Medical complications, I'm not going to spend a long time on today, but a lot of these patients are elderly, older, with medical problems, and there are things that happen, and I've seen a lot of dysrhythmias occur. And my business partner did a case, and about a week later, this patient had so many medical problems, actually had to go to the hospital with a medical emergency and passed away. And even though it had nothing to do with him and his procedure, he has become very gun shy of doing these types of procedures anymore. We're going to talk about implant changes, abutment angle changes, malocclusions. And so here's a case. And this man had bad port dentition. You can see not a lot of periodontal disease, good attached gingiva, a little bit of an unusual occlusion with his teeth on the right out of occlusion. They are dental implants. He has 3 dental implants, and he really wanted to keep these implants and utilize them if possible. Never make promises to your patients. That's another tip for you, until you do your workup, because you don't know if these implants will be in the proper plane of occlusion, if these implants will be at the proper depth, given that we don't know right now how much bone removal we are going to have to do. Fortunately for him, we were able to use these implants, which is partly why I want to show you this case. His lower teeth are failing also, and he does plan on coming back to get his lower jaw done at some point. So we proceed through our case, and this patient is under anesthesia, and I cannot get this foundation guide to fit. And it turned out that it was my fault, because I was only supposed to keep 1 tooth in the mouth, and there were 2, and they were splinted together. So I needed to separate them and remove the 1 tooth in order to seat the foundation guide. The second problem seating the foundation guide was that the foundation guide would not seat where the incisal nasopalatine incisal nerve was, and it turned out that I had to relieve this area on the bone foundation guide in order to see the guide. But I will tell you that since this time period and the Sequence has now automatically relieved these areas. But finally, I got the guide seated and proceeded with the case and placed the implants. And I placed 3 more implants because he already has 3 fully integrated implants. And now we have the x-ray showing the other implants. I was able to reach out to the doctor who placed these implants, and very nice guy, got on the phone and spoke to me and helped me with ordering the proper parts and pieces. But the only downside was he was not correct about the implant sizes on one of the implants. So I was able to place the parts and pieces on 2 of the implants, but I just also wanted to show you that I've been able to work with different implant systems within Sequence, and I've now used 4 different implant systems that they've been able to work with. But you more so need to check with your implant company to make sure they have all the proper prosthetic parts to be able to do tooth-in-a-day cases, such as angled, low-profile abutments, and some type of temporary coping. And I seated this prosthetic, but we have another problem. Again, I'm showing you problems today. There's a little bit of an open bite. And so I do want you to realize that this does happen even using digital, and we're going to be able to get through it. We're going to be able to adjust these teeth at the end. It's not a horrible open bite. And this really won't be too difficult to adjust at the end of the procedure. We're curing the case. And I decided not to show photos of this because I was going to speak about medical emergencies. My patient was asleep, my lab person had a pulmonary embolism in the other room. And it's really good news. Everything turned out fine, but we stopped what we were doing. We went over, resuscitated him, and we thought twice about resuscitating him because we knew he was a Cowboys fan. However, in the end, we decided to do that. And obviously that's a joke, but he did just fine. So everything turned out okay. We got him to the hospital. So this is actually me making the prosthesis, turning the prosthesis in long-term provisional, which I don't recommend because now instead of finishing the surgery, now I'm going to spend 45 minutes doing this and then going back to complete my surgical procedure. Or I take it back, I've completed the surgical procedure and stitched it up, but now I have 45 minutes to go to do this. And I've filled in everything, and now I'm cutting down all the excess material. And, you know, not bad for an oral surgeon, not perfect, and certainly not as good as my chair side person that would normally be doing this. And I want to show you here that when I was working with this prosthetic, just like if you move an implant, you can adjust the hole. You can cut a new hole. So you can still work with these, even though the whole plan is set up from the beginning and you know where all the implants are. There is always that concern. Well, what if one of these implants doesn't work and I need to move it? Well, then move it. And you can just adjust the holes or make a new hole. So there's a lot of workarounds. I feel like I've been through a lot of little issues, given that I've used lots of different conventional labs and work within Sequence. And so I've been able to work through all kinds of changes that I've wanted to make. You know, if an implant doesn't torque very well, sometimes I'll take it out and put in a bigger implant. So anyway, this is his occlusion, and we were able to adjust it. He was happy as could be. And I'll show you some final photos at the end of this man. So here's a situation of a lost coping. Be very, very careful. I do want you to know that throat packs are mandatory for these cases. There's a lot of small parts and pieces flying around, and I use throat packs all the time. And somehow a piece got past the throat pack, and so we had to take him to the hospital and essentially take a number of x-rays, and there's nothing in the neck or upper airway. There's nothing in the chest. And we found the temporary coping with screw past his stomach in the small intestine. So fortunately, this turned out okay. And the object never caused any problems. He was able to pass this object. So, but this is a complication. Another complication that does come up frequently is very easy to have these abutment angles just not exactly where you think they need to go, which is why I recommend that you place first the straight abutment pins. Make sure that they go through this prosthesis in a passive manner. When the prosthesis is seated, it should go down passively over these copings. These are my little modified pins I use to make sure that I can place these device before I put the copings on. But here you can see it's impinging on the plastic. So we're just going to either open up the plastic or we're going to re-angle the abutment. And so in this case, we open it up a little more, and then we're able to seat this passively. And this is his final occlusion. Buccal plate fractures. Most of the time, we cannot put implants in these sites. Luckily, these implants were going deep and very palatal, so this still worked out. I was able to bone graft, but if a buccal plate fracture, which does happen in it, you have to move these implants. Maybe we can put one back here in this bone, but things have to be moved, and you'll have to alter your device. A large buccal plate fracture, you cannot just stick the implant in there, bone graft on top of it. This is a perfect example of a case where was sent to me. I did not do this case, but with a failing implant, and it was placed into an immediate socket with a large fenestration with some bone graft, but it doesn't stick very well. And so this is a failing implant I had to take care of. Again, another case of not the best occlusion. And he's a very easygoing patient, and we ended up getting him through the temporary period. And all of these problems can be fixed with their final device. And this is a full zirconia upper and lower. And he was extremely happy. Beware of custom guides, even though, you know, I'm promoting custom and digital. I've read a study a while ago that there can be error rates up to 2 millimeters on implants. And I believe, but I'm not sure, but this is probably why when we are planning implants, there's always that 2 millimeter buffer that the implant companies or the planning companies want around any nerve. So I'm big into planning my own implants. I don't rely completely on guides. When I see the implant, I still take the guide off at times and have to change that implant to where it's in the perfect position. And this is a case with some antiquated software. This is not the software InSequence uses. And both implants were placed in a fully guided method with what looked perfect on the guided plan. And then it's a little too close to the tooth. It still worked out. Seems that her implant and tooth looks good and held up, but this was a little too close for comfort. And this is a case of a friend or a colleague of mine who is a general dentist, but places a lot of implants and does a nice job. He did it fully guided. And this is what he ended up with a fully guided case. And again, we're not here to throw him under the bus. This can happen. And so this implant was failing and had pain and pus around it. Here's a case with a upper device, and what happened here was the foundation device and the occlusion didn't seem like it was, well, the teeth occlusion was not perfect, but the foundation guide was seated fully and had good adaptation to the bone, and everything was seated perfectly. So in this case, I cut off these straws and I evaluated his smile line, and I knew he could use more incisal display anyway. So I did not pin that anterior hole, and I placed the pickup material, but then I held the anterior teeth a little more inferiorly into the occlusion I wanted, and then cured it. So we put this material in, cured it. I finished the case. And this is right after I finished curing it, which is a lot better. Now he just needs some adjustment on these teeth. And this is realistic for all of you. You know, there's going to be some adjustments on these long-term provisionals, and a lot of things that little tiny things that the patient may need to keep a list of that they may need changed for the final long-term provisional. And he was happy as could be. And the next day he went to his restorative doctor who completed the adjustments. Here's a case of an upper, this is back when I did a conventional method, and we have upper teeth. This is a, we placed the implants, and we would always have a backup duplicate, and we have the implants exactly where we want to go. And then we either, you know, usually we remount the case. The most difficult thing, as I've told you, is getting the occlusion proper. And I've had a lot of trouble with getting the occlusion proper until I, depending on which lab I was working with. And I really had to dictate exactly how I wanted them to do these cases. But there's often very large open bites, and this is after some adjustment. And I think the reason is because when they're using a conventional denture and then you're removing bone, it tends to rotate upward in the anterior region. Special thanks to Tremaine for helping me come up with this graphic. And she ended up with a good result. So for these cases, there's a lot more mounting and a lot more steps you need, as I've told you in the first and second lectures, to complete the cases. I think we're almost finished here, so sorry I'm going over a little bit, but I think this is where we're going with our profession, but this is my opinion. So on these types of cases, I think we may be heading towards something a little more crown and bridge like. The problem with crown and bridge is that it's a lot more expensive. So so maybe if the cost can come down a little bit, we could do an immediate load case and then eventually turn it into crown and bridge. But it doesn't always work because, you know, you can't really remove bone for those cases, and then you may not have enough thickness for immediate load provisional. But this man had failing dentition. We had to do bone grafting, and I did a ridge split, and we came back a different day to do the upper. And for his lower, we planned carefully his implants, placed the implants in very precise positions. And this was a case I did a while ago. So we used a lot of quick bridge attachments. And we have 8 precisely placed implants. And we did make an immediate load prosthesis, which turned out very nice. And after healing, he had a digital workup done, digital scans, and he had this turned into crown and bridge work. And at first, when I was doing this case, I did not think this was going to turn out good. But it actually turned out okay. And because he has a low smile line, he did not have to have pink porcelain here. But this crown and bridge work, according to some authors, is a lot more hygienic, easy to floss, easy to clean under. But the downside is a lot pricier. So, in summary, we have to have good patient selection for these cases. Not everybody's a candidate for these cases. I really like to educate the patients with photos and models. Please be realistic with the expectations. Some of these slides I showed you where we need to tell them about the bulkiness of the provisional device. It may not go back as far. The occlusion will have to be adjusted more, but they get this opportunity to heal and have fixed teeth, and then they can make changes with the final. But please let them know there's still maintenance involved. They're not finished with dentistry just because they've removed all their teeth and had a fixed prosthesis placed. And always give alternatives. Somebody mentioned last week, why don't I talk about or recommend? They said I don't recommend locators, but I do recommend locators. It's just that this lecture series is related to fixed prosthetics, not locators. So that's something patients do, but the failure rate under locators is fairly high. A big study done recently, 39 out of their 40 patients would absolutely recommend this surgery again. And here's a final photo of the man that we just showed you. I asked the restorative doc why he left the anterior open a little bit, and he said because the anterior lower teeth are failing. But he was happy as could be. And she may have been, she was ecstatic with her teeth. She had no teeth and she loved her prosthetic. And so I can't tell you the satisfaction I had as well, being able to be part of the joy that this lady had when she had fixed teeth, a nice smile, and can chew again. It doesn't have to wear a denture. So thank you so much for attending. And I really appreciate your time.